Bismillahirrahmanirrahim. I will just share with you some interactive
Your slides are not
cardiac
showing. Okay.
cases. This session is interactive. I would like you to participate. Basically, I don't want to test your knowledge. You are all very well
Can we have the
learned
timer on,
people.
please?
But your participation will make it worthwhile. My first case is a 32-year-old girl who complained with shortness of breath and palpitations. And she underwent a transthoracic echocardiogram which showed an ASD and a mass in the RVOT plus left-sided persistent SVC. The echocardiographer thought that it could be possibly a lipoma. For further evaluation, he suggested a transesophageal echocardiogram, which didn't add much to the information, just confirmed the same findings. And the only impression or conclusion was that a cardiac CT is advised for further evaluation. A cardiac CT was performed, which you can see shows a large mass in the RVOT plus the left-sided SVC in the 3D image. The same mass in the other view, large mass attached to the interventricular septum in the RVOT, and also the ASD in the second image. Now, as I said earlier, that the echographer thought that it could be a lipoma. But when I was made the CT value of this mass, this was almost equal to that of the myocardium. So in my opinion, that could be anything but lipoma, because lipoma usually has a negative CT value. Now I will ask for your opinion. What do you think about this mass? Could it be still a myxoma or a lipoma or rhabdomyoma or fibroelastoma or hemangioma or anything else? Sorry? Any suggestion? Just a guess. I don't want to test anybody's knowledge. And rhabdomyoma, why do you say so? Well, that is a possibility. Anyway, the patient underwent surgery, and this is the surgical removal of the tumor. And on the right side, you can see the tumor which was removed, large spherical mass removed surgically. And when histology was performed in this case, I'm sure you must be familiar with this type of histology, even from your undergrad classes. This is, can anybody give me some guess what this mass could be? Sorry? Any guess, any rough guess? It actually turned out to be a thyroid tissue, an ectopic thyroid tissue inside the heart. Okay? It was normal, mature thyroid tissue, not malignant tissue, just in the ectopic location. And the normal thyroid was in its place. The patient was still euthyroid. This is a very, very rare condition. Only about 20 cases has been reported so far. And mostly these cases were on the right side of the heart. And surgically, this patient got removal of the tumor and the ASD was repaired. The patient is doing fine. The second case is a 9-year-old girl who presented with shortness of breath and easy fatigability along with palpitations. And physical examination was unremarkable except for a short systolic murmur. This is the chest X-ray and electrocardiogram of the patient, which is almost non-specific. Patient underwent an echocardiogram, which suggested that there could be a right coronary artery to MPA fistula, along with trivial MR. And for the confirmation of this diagnosis, a cardiac CT was performed. And these are the axial slices of the cardiac CT. Now please look at these axial images and give me some idea. Do you see something abnormal in this case? Yes, RC is dilated and tortuous, quite big RCA. Anything else? Absolutely, absolutely. This is draining into the pulmonary trunk. So this is basically the echo. Do you think the echo diagnosis of a fistula was correct? Do you think that was a correct diagnosis? Yes, that is the correct diagnosis, because this RC is ultimately draining into MPA. But is that the complete diagnosis? That is actually not the complete diagnosis. It is draining into the MPA. Actually, the main coronary artery, left main coronary artery, is arising from MPA. So this is actually the anomalous origin of left main coronary artery from MPA. So there is dual pathology in this condition. One is that there is left to right shunting through RCA to the MPA. Then the second abnormal pathology is that there is myocardial ischemia in the left coronary artery territory. These are the 3D images of the same patient showing the abnormal origin of left coronary artery from main pulmonary artery. Just for quantification of ischemia in this patient underwent a stress-rest myocardial perfusion SPECT study, which clearly showed reversible ischemia in the left coronary artery territory. This is the quantification of the same. And so the ultimate diagnosis was L-kappa. There are other names for this condition also, Bland-White Garland syndrome. This is abnormal origin from MPA, and this is a very rare condition. And treatment options are it may be reimplanted, or it may be connected through a tunnel, or directly reimplanted. My third case is a 16-year-old girl who presented with blue coloration of lips along with shortness of breath. Her physical examination was unremarkable, except that she had central cyanosis and clubbing. This is the electrocardiogram of the patient, which is almost unremarkable. Chest X-ray of the patient, which was passed on as just normal. If you can see something, you can suggest.
How is the pulmonary artery here more prominent?
It was more prominent, yes. So the patient underwent echocardiogram, and there was suspicion of sinus venosus ASD with right to left shunt. But there are other things which are not compatible with this diagnosis. If you think that it is an ASD with shunt from right to left, this has to be an Eisenmenger situation. And for that, the RA and RV has to be big and RV has to be hypertrophied and pulmonary arteries has to be big. But in this case, in this echo, you can see that RA and RV were just of normal size. So there was some paradox. So for the confirmation, this patient underwent a cardiac CT. These are the axial slices. Now please look at these axial slices and you give your opinion. Could it be a case of ASD, VSD, PDA, partially anomalous pulmonary venous drainage, or none of these? Do you see any abnormality in this case?
Right-sided chambers are enlarged. Right
Are
atrium,
enlarged.
right ventricle.
Really? Are really enlarged?
Here, for example, when you look at this,
It's almost not the normal. By the way, RV is normally bigger than LV, volume-wise. Though in the axial slices, it usually looks smaller than the LV, but actually RV is normally bigger than LV, even in normal people. Anyway, the right answer is none of the above. This is just the normal CT. I could pass it as just normal CT, but I did something extra. I did a wide reconstruction of this patient. Okay, this is a wide reconstruction of the same patient. Now look at the images and see if you can find any abnormality. AVM, yeah, wonderful, wonderful. There's a big mass in the left lung. There is another also on the right side as well. So there is bilateral communication between pulmonary artery and pulmonary veins. This is the same patient, just the wide reconstruction. The actual pathology was outside the field of view. This is the 3D image of the same. Okay, you can see bilateral pulmonary AVMs. Okay. Anyway, this patient underwent, these are treatment options. This patient underwent coiling of the pulmonary AVMs on both sides. And the X-ray on the right side shows the coils in place. These were done by the pediatric cardiac physician, Dr. Asfar Rahman. So the take-home message in this case is that sometimes the pathology may be outside your field of view. So keep your mind open, okay? And this case was accepted for 30 minutes of CPD credit on MedShare. The next case is a 10-year-old child who presented with increasing cyanosis and was referred for cardiac CT for detailed evaluation. These are the axial slices of the CT. These are the short axis and the 4-chamber views showing communication between LA and RA, yes, ASD in both views, and also communication between LV as well as RV, okay? Now, the question here is, you can see two arrows. One is red, the other is blue. Can somebody help me which structure is marked by the red arrow and which structure is marked by the blue arrow? It's TGA. Why do you say so? Wonderful. The structure marked red is pulmonary artery, and the structure marked blue is is aorta. Aorta is arising from the RV and pulmonary artery is arising from LV. So this is TG. What type of TG is it? DTGA. In DTGA, aorta is on right side. This is the 3D image of the, you see parallel vessels. The aorta and pulmonary artery are parallel in TGA. Now there is another question. There are again two structures marked with red and blue arrows. Can somebody tell which structure is marked by red arrow and which one? Wonderful. And the blue one is?
It's hypoplastic aortic arch.
Yes, wonderful, wonderful. So the PDA is even bigger than the aortic arch. Okay. So what is the correct diagnosis? ASD, VSD, LTGA, PDA with mild coarctation. ASD, VSD, DTGA, PDA, mild coarctation. AVSD, LTGA, PDA with severe coarctation, or none of the above. You have all the components, you know all the components. What is the right diagnosis here? Yeah. It's a B. It's ASD, VSD, DTGA, PDA, and mild coarctation. Okay. In congenital heart disease, sometimes the important question is to differentiate which one is the RV and which one is the LV. There are different points like trabeculation, the wall thickness, and the others. But the most reliable point in differentiating is the outflow tract. The outflow tract of the RV is muscular tube. If you identify a muscular tube, then that surely that structure is the RV. Okay. So I think I can stop here. The time is up.